Sure. You guys hear me okay, right?
Yeah, we can hear you, and the presentation looks perfect.
Perfect. All right, so to get started. So this case is about a 77-year-old woman. She has a past medical history known of hypertension, hyperlipidemia, and osteoporosis, and she presented following 2 fainting spells that happened 1 day prior. So the first of these 2 episodes was unwitnessed. She was feeling at her baseline, didn't have any prodromal symptoms at the time. She was doing some physical activities, she was raking some leaves, and the next thing she knew, she woke up on the ground without any recollection of the event or any recollection of any head trauma. Afterwards, she felt a little bit tired, but otherwise was asymptomatic. Now, 4 hours later was when the second event occurred. So this second event was witnessed by her husband, who was sitting next to her on the couch, and basically said that she became very pale, slumped over on the couch, did not have any head trauma, was not responding to him, his verbal or tactile stimulation for what he thought was about 4 minutes, but may have been a little bit less. Her husband then noted that she had a left-sided facial droop during this event, which resolved not too long after she woke up. She also denied any prodromal symptoms prior to the second event. And for the last 2 weeks, she noted that she was having some increased fatigue, intermittent subjective fevers and chills, which self-resolved, and also noting a decreased appetite. But when asked about weight loss, she said she hasn't lost any weight. A little bit later, our children arrived to the bedside and endorsed that they visited her about a week ago. And at that time, they noticed that her gait was a little bit more unsteady than normal, and that she was having intermittent paranoid delusions, that she was having outbursts where she was accusing people of stealing from her. The night of the second event, her husband was concerned that she was having a stroke. They live outside Boston and went to a local ER. And by the time she got to the parking lot of the ER, her facial droop had resolved and her mental status was back to baseline. So he decided to return home, went to bed, and the next morning he felt bad. He felt like he made a mistake, drove down to Manhattan where his daughter lives so he would have more support, and took her to Mount Sinai West, which is their local ER. And at that point, the patient was at her baseline mental status. So do you guys have any questions? Any information you want to know?
Anything else you want to know? So I guess we had these like fainting spells in these elderly patient, and then these kind of like non-specific complaints kind of in the week or 2 prior to that. So I guess anything else you want to know either about the fainting spells or about the kind of subacute symptoms in the lead up to it?
Or you could put it in the chat.
Exactly.
Any seizure? Oh,
Vince, you say any seizures?
yeah, any like seizure like activities, body shaking?
No body shaking. No body shaking. Just that she wasn't responding to his verbal stimulation or tactile stimulation, but there was no like epileptic activity that they noted. No body shaking, nothing like that.
Any headaches or vomiting?
No vomiting. They didn't note any headaches either.
And then Carlos has in the chat if the patient had any urinary symptoms.
No, she didn't endorse any urinary symptoms. She said she had no dysuria, no blood in the urine. Yeah.
How quickly did she return to baseline after these episodes?
So the first one we don't know. The second one that was witnessed, the husband said that it took her 4 minutes to come back to her baseline mental status. However, it's definitely subjective, and we don't know exactly how long. He thinks it was may have been shorter than that. So we can think maybe a minute or 2.
Sorry, did you already say on the first slide, what is their past medical history?
Hypertension, hyperlipidemia, and osteoporosis.
Okay.
Was the patient kind of diaphoretic? Any other signs of like hypoglycemia? Did you ask about eating or like the meals and all that?
Yeah, so the only other sign that the husband had mentioned during that second attack was that she became very pale. I didn't necessarily note diaphoresis, but said she was very pale. And over the last 2 weeks, she was eating a lot less than normal, much decreased appetite, which is different from what her baseline. Normally very functional and eats all of her meals and has a good appetite. So this was something that was new. But no vomiting. I don't know who asked about vomiting, but no vomiting.
Hi, everyone. Dr. Sharma here. Hey, Randy.
How are you?
I'm good. How are you?
thanks.
So, yeah, very good presentation so far and very good questions. You asked for like hypoglycemia, and somebody asked about the seizure-like activity. So, pretty good questions, and we have a very elaborated history what happened. So, what are main symptoms here which we are dealing with? And like then we have to like ask the relevant questions and can come up with like, okay, this is what the presenting this is the one problem or like the couple of problems we're dealing with. So what are we dealing with here? What's this patient is presenting with? There are multiple like glaring symptoms here. What's the number one complaint? Anyone?
Syncope.
Yes, syncope, right? So good questions, like how long the patient was down, right? Somebody asked that. Why that question was asked?
I asked how quickly she returned to baseline to see if there was any kind of like postictal, any suggestion that it would have been a postictal state.
Yes. Yeah, there are two events here noted. The one was when the patient was by herself, and the other one was when the patient was sitting in front of the husband, right? And she's in the sitting posture and she became pale and then lost consciousness. And then, like Randy said, could be like very subjective to like, say how long the patient took to come back to baseline, right? So anybody want to tell me what like syncope is? How do we define it?
And I think this is the question Dr. Singh asked in the chat. And if I remember correctly, I think it's the very first slide on her syncope presentation. If anyone wants to take a stab at kind of defining or explaining what that is.
I think if I remember, it was like transient loss of consciousness with return to baseline. So
yes,
it's nothing like a postictal state or anything. Yeah, return to baseline, normal baseline.
Anybody wants to add more? Yeah.
No, I think lady did such a good job. It is like transient loss of consciousness. So loss of consciousness being key. And then in the ESC guidelines, even the ACC guidelines, they actually recently added the etiology in, right? So it's now defined as a transient loss of consciousness due to cerebral or due to global cerebral hypoperfusion. So they're telling you why it's occurring, thereby taking the differential away, right? So transient loss of consciousness due to global cerebral hypoperfusion will return to baseline within minutes, right? Most syncope return to baseline very quickly. Joe, you put it in the chat.
Yeah, he did that's a perfect definition. So the other thing which he also added in the definition is spontaneous. That is also very important in the definition. Like lady, you asked like about hypoglycemia episode. If somebody even on the floor becomes loses consciousness and you like give them D50, they come back to consciousness right away. There is an intervention there. Right? So like if the consciousness comes back spontaneously, like rapidly, and and it is associated with global hypoperfusion, like Vasundhara said, like that's the definition of syncope. So to narrow down so many causes for which a patient can lose consciousness.
Okay. Thanks, Dr. Sharma.
Okay.
All right, any more questions or we can move on to the next one?
I think you can move on and maybe tell us more of the patient stories.
Sure. So, like Karina alluded to, past medical history only notable for hypertension, hyperlipidemia, and osteoporosis. No known surgical history, no known allergies, no pertinent family history at this time. Medications that she takes chronically, she takes enalapril 5 milligrams for her hypertension. She takes atorvastatin, and she takes alendronate for her osteoporosis. Some notable social history: does not use any illicit substances, no alcohol use, no tobacco use. Typically, she's very active, independent in all of her ADLs. She has hobbies. She enjoys walking. She enjoys cooking. She enjoys vegetable gardening, and she lives with her husband. Just to note, she doesn't have any history of dementia in the past. I'll put that out there as well. So review of systems, just putting it here, even though I did mention most of these. The notable positives were these subjective self-limiting fevers and chills. This weakness, fatigue that was progressive over the last 2 weeks. These balance disturbances that the family said they noticed about a week ago. These 2 syncopal episodes, and these paranoia episodes that the family had also mentioned a week before this happened. So physical exam, blood pressure, 118 over 68, pulse was 84. Temperature notable for a fever, 102.9. Respirations 18 and O2 saturation 95% on room air. Physical exam, she appeared very comfortable, ANO times 3, was able to talk in full sentences, was very aware of her situation. HENT exam was grossly normal. No lymphadenopathy on neck exam, no thyromegaly. Cardiac exam was notable for a systolic ejection murmur, 3 out of 6 in intensity on the right upper sternal border, but otherwise regular rate and rhythm. Wasn't bradycardic, wasn't tachycardic. Lung exam was clear. GI exam, abdomen was soft and non-tender without any guarding. No lower extremity edema. Her extremities were warm. We did a full neuro exam. Cranial nerves were intact, no focal deficits. Sensation and motor in the upper and lower extremities were preserved from 5 out of 5. We did observe her gait, and she did not walk with ataxia to our exam. Finger to nose test was normal as well, no pronator drift, and we didn't observe a facial droop. Skin exam, we didn't notice any rashes, bruising, no ulcers, abrasions, nothing like that.
And just Joseph was asking any nuchal rigidity.
No. Good question though. Any other questions before we do the problem representation? No. So who would like to take a stab at the problem representation?
Joseph has a question, and maybe he can volunteer to do the problem representation after we answer his question. But he's asking, was she at her baseline mental status? And actually Frida has asked, any recent travel or any recent procedures?
So Joe's was what's her baseline mental status?
Yeah, she was at her baseline mental status.
When we saw her, yeah. So her baseline mental status, ANO times 3, fully independent with all of her ADLs. Husband and family was at bedside and confirmed that this is her baseline mental status. As far as recent travel, so she does live outside Boston with her family. So travel, notable for coming from there down to Mount Sinai West to the ER to be with her family. But otherwise, no travel outside the area or anything like that. Was there another part to that question, or just the travel?
Or procedures?
No procedures.
So Joe and Frida, can you also share with everyone why you asked those questions?
My thinking is patient with waxing and waning mental status, syncope, fever, elderly, meningitis, encephalitis is on there.
Good. You want to get the badness out of the way.
Yeah.
Excellent. Frida?
I mean, with the altered mental status and the fever, it could be some kind of an infection. So that's why I wanted to know about recent travel. Also fever and a murmur, which I'm not sure if it's new. Also thinking about endocarditis, like did she have any recent procedures that put her at risk of like a blood infection, something like that?
Yeah, great questions.
Anybody
So-
wants to? Yes, Joseph. Yeah.
So we have this elderly lady, 7-year-old, hypertensive, hyperlipidemic, with multiple episodes of syncope, with rapid onset and rapid recovery to baseline mental status, presenting to the ED with waxing and waning mental status, as well as fever, otherwise under markable physical exam.
And there's one more thing, right? The husband mentioned about a neurological symptom, which improved. That's why they dropped the idea to go to the Boston ER.
Yeah.
That's also an important piece of information, right? Which is the facial droop they noticed. And that was significant enough that they had to like take the patient to the ER. But you know how things are, like can be, when it got better, they came back, but then they finally decided to come here. So it's fever, it's facial droop, and paranoia. That's another thing. Like families telling that she never had any psychiatric illness and now she's paranoid of her own kids. So that's there too, facial droop, fever, and multiple syncopal episodes, like a variety of symptoms.
Yeah, great job, Joe. That's pretty much what we had here as well. So an elderly woman with a past medical history of hypertension, hyperlipidemia, and osteoporosis, presenting following 2 syncopal episodes without any prodromal symptoms, since resolved facial droop, and noted to be febrile on presentation with a non-focal neuro exam on our exam. So any ideas for differentials?
CNS infections, abscesses, I guess, or encephalitis.
Mhm. Yeah. Any others?
Also the I mean, I'd be worried about cardiogenic syncope because it was so sudden. And she has a murmur on exam and she's having kind of like fever and some non-specific constitutional symptoms. You'd want to rule out infective endocarditis as well, I think.
So on the chat as well, Joe kind of reiterating CNS infection still top differential, and Frida agreeing with the same, thinking it's maybe more something subacute.
Okay, great. So the differential we came up with, and you guys got a lot of them. We were definitely worried about cardiogenic syncope, whether it's arrhythmogenic or valvular secondary to the aortic, a possible aortic stenosis, since we had that murmur in the right upper sternal border. We were concerned about possible seizure activity, depending on the history of, how accurate the history was. Vasovagal syncope, her first episode, she was outdoors doing activities, so definitely could have been vasovagal. CVA versus TIA, also infectious meningitis, encephalitis, bacterial endocarditis, bacteremia, and obviously the common UTI pneumonia.
And Frida just posting in the chat as well, I guess something that kind of unifies everything. Lyme disease can give meningitis, facial droop, and heart murmur.
Yeah, that's a great thought.
So I know our next few slides kind of touch on like workup, but also along with Dr. Singh and Madeline's project, like specifically like cost-effective workup. So like appropriate workup, looking at cost awareness for that. So what initial workup would you guys want to do? So if you saw this patient, she comes into the emergency department, you're like on your ED rotation there, like what's the initial workup that you're going to order or do?
And let me just ask Randy, pretty low cost intervention. Were orthostatics checked?
We did not check orthostatics.
She's
I don't think.
syncopized twice.
Yeah.
And
Probably should
did
have
we
been
have a
checked.
list of medications?
Of what she takes at home.
Mhm.
Yeah, just alendronate, enalapril, and atorvastatin. Just to say.
Okay, so you've got an ACE inhibitor on there. Okay.
Yeah, but no, we did not check orthostatics, and probably should have.
Yeah, I mean, as a general rule, when it's a syncope case, no, I mean, and I like our differential a lot, but when it's a syncope case and you have a patient on an antihypertensive, they've been febrile, they've probably got a lot of insensible losses. Like as a general rule, orthostatics should just be checked by the medical team, not even sort of delegating to the nurse.
No, definitely.
Yeah. Somebody comes with like syncope, that's the most cost-effective thing you can do to rule out one of the differentials.
Yeah, definitely.
So in the chat, Workup Carlos said CT head, and Noor is saying CBC, lactate, blood culture, UA, so infectious workup, CT head, EKG, TTE, and Francisco, TTE, Lyme serology, basic labs, EKG, CT head, inflammatory markers, and Vincent telemetry monitoring. Which I guess is interesting, thinking about like how often we have patients presenting with syncope and we reflexively want to put them on telemetry, but like starting with an EKG first and seeing what it is that you're dealing with or looking at.
So the people, so just a second before we move on, the people that said head CT, what are you hoping to catch?
Yeah.
Who said head CT?
Yeah, multiple head CTs were
Carlos,
mentioned.
Francisco, anyone. And this is just, it's a frank discussion, right? This is a discussion we would have it round. So anything you can throw at me. For what will this woman's presentation show on head CT?
With the questionable facial droop, you might see like a small stroke, even though she doesn't have any neurodeficits.
You're thinking when she had the facial droop, she may have had an ischemic event. Her facial droop then resolved, but you might find an infarct?
Maybe.
So if
also
you,
with
if
this,
you
like,
infarcted, then the facial droop would persist. In order for it to show up on head CT, the neurodeficit wouldn't go away. This is something that neurologists have taught me over the years.
Okay.
Like, don't look for an infarct if the neurological deficit has not persisted. TIAs, by definition, don't show up on imaging.
So yeah, like Vasundhara said, if you're saying the focal deficit disappeared, right? Then by definition, it's not stroke.
I mean, I don't know with facial droop specifically, but I've had a patient who had transient dysarthria who then had an infarct that was picked up on, I can't remember if it was on the subsequent MRI. But
did the dysarthria resolve?
It resolved. She had 2 episodes of it in the ED. And then when I saw her, she wasn't dysarthric and she had a CT head eventually.
Yeah. Did the infarct like coincide with like, the location with the presentation? Did she develop another focal weakness anywhere? When you did the
no, there
imaging?
wasn't.
I would even argue in that setting. Yeah. Go ahead.
Yeah.
I want, so not just the syncope, but we're saying the patient has like some delirium, had paranoia, like psychotic symptoms kind of. One of the presentations could be also like a lesion in the brain, not just like a stroke, for example, could be anything else. The patient also has a fever, we might see some.
Also with the new onset paranoia in an elderly patient, and there's like, that's never happened before. I think you'd want to rule out any organic causes for before classifying it as like a psych disease.
So can we like differentiate the, our thought process into like, do we need CT head to diagnose or to work up syncope versus what we think in this patient who also has paranoia, fever, and other symptoms too, right? Let's say we had a patient who just presented to you with syncope. In that situation, and everything is normal, there is no other finding, no other symptoms, like what benefit would you have by scanning the patient's head or by doing CT? Let's put this question this way. Any thoughts?
Yeah, exactly. I guess if a patient is just syncope, you wouldn't run doing a head CT if you, for example, have orthostatics positive. But this patient, I mean, she kind of presented with a syncope, but I feel there's so many things behind the syncope that, like, the syncope may not be the main issue. Could be like the final presentation of another problem.
Absolutely. Yeah. In this case, I think, it's not a bad idea because she had other symptoms too. But if we just talk about syncope, what part of the brain, if you have a stroke, can lead to syncope? Or do you have syncope as a presenting symptom of a stroke?
I guess technically, if we go by the definition, a stroke wouldn't cause like a syncope itself because it's it would be like a mimicker.
Yes.
Because you're not decreasing cerebral perfusion, but yeah, would be like either a big stroke that of course would give a lot of deficits, or like brainstem posterior.
Yeah. If somebody's losing yes, two things. If somebody's losing consciousness, then the patient is having big, massive strokes, then it would not just be a loss of consciousness which recovered spontaneously. Then you will see big group of muscles which have weakness, and the other symptoms which will be literally screaming at you that the patient had stroke, right? So a minor stroke which you are not able to find on the physical examination leading to syncope they don't go hand in hand, right? Also, if it's a minor stroke, if it happened in the posterior cerebellum, then you can have syncope associated with it. So you have to examine the patient head to toe, and if you find any gait instability, if you find any focal weakness, then only go with the CT head. Otherwise, in a patient presenting with just syncope, CT head does not carry that value. Having said that, in this patient with fever, paranoia, and other symptoms, I don't think that getting a CT head done would be a bad idea. Agree?
Yeah, I will. Yeah, absolutely.
Yeah.
And I agree. I mean, but the reason I'm forcing you guys to say, why CT head, I agree with Frida. If this person is going to get an LP, then yes, you want to make sure there's not a space occupying lesion that's going to, ruin your LP and cause herniation. So that is a really good reason, right? And to go with Carlos, so there's a CNS infection and there's a brain abscess, that's a really good reason. But to Karina's point, right? So when you're thinking about small, subtle strokes in which the presenting symptom has resolved, it's highly unlikely you're going to catch it on head CT. And so if you did this whole workup and you're still suspicious about that, go for a brain MRI, right? If you're thinking HSV encephalitis, you're not going to catch it on a head CT. You need an MRI to see the temporal enhancement that is typical of encephalitis. And so you got to know what you're looking for on a study before you order that study. Just because it's a catch-all kitchen sink that the ED throws at everyone, I feel like it sets us on a back foot, because you walk in, you go head CT normal, and then you shut down the CNS thought process. There's still stuff happening in the CNS, right? Okay. We can keep going.
Yeah. Jackie, should I go on to the next?
Yeah. If you want to go ahead and show us what was done.
So this was the very early initial workup. CBC, notable for an anemia, hemoglobin of 10.7, thrombocytopenia, platelet count of 77. Hepatic function panel noted for AST greater than ALT, 93 to 74. An indirect bilirubin and mild indirect bilirubinemia. Total bilirubin was 2.0, indirect bilirubin 1.1. The BMP was normal. The troponin and the UA were ordered and were found to be normal as well. Do we stop here to discuss further workup, or do we have time for breakout rooms, Shaggy?
So I think if we want to, it might be easier within the group, but I guess kind of considering what everyone was thinking initially, it seemed like CNS obviously was like very high up. I'm kind of seeing these initial labs, like has it changed your differential? What are you thinking of now? And what further workup are you going to order at this point? Like say the ED has given you this admission, patient admitted for workup of syncope, and you have these labs, like what are you thinking is going on, and what would you want to do next? So I see Karina has put in hemolysis labs, reticant, LDH, hapto, peripheral smear. I guess what's your kind of thought process, or what are you thinking, or what are you concerned about might be going on now? Okay, so Karina's saying a hemolytic anemia, some parasitosis. So can you be more specific, Frida, infectious workup? So what else do you want to do at this point? So Frida saying blood smear and to check for Babesia. And what makes you concerned about that, Frida? And Lyme as well.
I think the fevers, the headaches, the thrombocytopenia, I mean, it could be part of it.
Other things also is like TTP, because of the low hemoglobin, especially the platelets, are we going to get like the ADAM-TS13 level and stuff like that? So I don't know.
Jabari saying as well, transaminitis also classic for tick-borne illnesses. So we seem to be very much still kind of thinking of infectious workup, concern for maybe some parasite, Babesia, Lyme, some tick-borne illness for that. Okay. And Frida wants the LP after getting her CT head.
So, so this was Dr.
Yeah, just a quick comment. Is Francisco still in here? Because he wanted the TTE.
Yes.
Yes.
Yeah. So Francisco, when as a cardiologist, when you examine someone and they have that systolic murmur, they've had these syncopal episodes, you've kind of now gotten this full clinical picture. What are you guys hoping to see on that TTE?
So basically, I mean, this case has many things, right? But if we have a new murmur and all these signs, of course, the most important thing, more than aortic stenosis, is to rule out a vegetation, right? And even the TTE could be completely negative, and we have a high concern, we need to go straight forward to the TEE. So that's something we need to keep in mind if we cannot find a reason in this case, and of course to follow the blood cultures, right?
Okay, but would you trigger a TTE before you check the blood culture?
I mean, the blood culture, we will have for sure 2 days of follow-up until we have a potential positive finding. So we need to do a TTE as soon as possible for sure.
No. Let's say it's Thursday today. You admit this patient. You're putting in orders. You put in for blood culture. Are you simultaneously going to order a TTE?
I would order TTE on admission. Yeah. because
yeah, that's the question. Why?
Why? I want to rule out not infective endocarditis. I want to rule out severe aortic stenosis. I want to rule out any other significant valvulopathy. Also, sometimes you have other findings. You may have more weird findings, like a cardiac tumor. You can find significant pericardial effusion, like many things that, this patient has other things, but I think it's important to have to rule out any structural abnormalities in the heart as well.
So if the patient had a very significant structural heart abnormality or valvular abnormality leading to 2 acute episodes of syncope, what would their presentation be like if somebody has valvular pathology significant enough to cause them have 2 acute episodes of syncope?
in the case of severe
Exertional.
It has to be exertional. The patient was sitting down. Yes.
aortic stenosis, yeah, but I mean for infective endocarditis, I mean here we have fever, could the patient have septic emboli in the brain or any other areas. So
Circling back to Vasundhara's question, like, would you simultaneously order TTE with the bacterial cultures, or you would wait for the bacterial cultures to go something and go to the next step?
I would order both on admission.
Yeah, I mean, and it's really good to have these honest discussions because we're all practicing medicine simultaneously. We're consulting cardiology colleagues on this all the time, right? So we've got to ultimately, as internists, right, which is what you all are at this current point in your training, as internists, it's really important to put together a story, right? Because ultimately, what we do best is tell a story. And if the story doesn't make sense, maybe don't order that investigation, right? If this person is sick right now, all of you are thinking about parasitic infections, there's labs that are coming up that are suggesting hemolysis, then why also go down another thought process, which would be infective endocarditis, et cetera. And even in infective endocarditis, the standard of care is to wait for your blood culture first. That is standard of care. If you're worried about pericardial effusion, I don't know, check a pulsus paradoxus. You know, and the reason I'm saying this is because we would walk in the next morning, and we're lucky, we walk into a lot of workup done already, and many hospitalists will actually cancel that TTE. They'll say, we have enough evidence of something else brewing that you don't also need to think about a second, third, fourth diagnosis, right? And then to that effect, what about the troponin? Why did we get that?
ED ordered it, not me.
I know, but you all work in the ED.
The bundle orders, like in the bundle. Yeah.
BNP is not on it. It's funny. I will also
said, Frida said, like, you know, if we are going to give fluid, if the patient is in sepsis and need to know if the patient has CHF. By that, then every patient who's coming in with sepsis, practically should get an echo done because you're going to treat them with IV fluids. Then everybody should get an echo done with that.
No, to that I'll say, Frida, they need a physical exam
to
determine volume status.
Exactly.
Not a BNP is notoriously inaccurate in obesity and CKD and various conditions. They need a physical exam, but let's keep going. We're running short on time.
So if you want to go ahead, Randy, and kind of show us what was done, and I guess then we can make sense of whether or not we were cost conscious in what we did.
Sure. First thing, we got an EKG, which showed normal sinus rhythm, no acute abnormalities on the EKG. The chest x-ray, I'm going to take my word for it that it was normal. It was not easy to pull off of Epic. There was a CT head being done in the ED, which was also normal, didn't show any infarct, didn't show any hemorrhage. And a TTE was ordered and then performed a day later. I put it here on this slide since it was ordered at that time, which showed sclerotic aortic valve without stenosis, no wall motion abnormalities, and some left atrial dilation, EF of 70%. So, yeah.
Quickly, does anybody wants to read that EKG? Anyone?
I apologize for the image from OnBase.
Yeah, like it's, but just quickly. Since we already have like talking in, in terms of like, parasitic infection, syncope, like what would you focus on?
Basically, conduction abnormalities, right? The PR interval to check for any bundled branch blocks. Also, if there is sometimes an abscess, basically the most important thing to check is the prolongation of the PR interval. Here seems to be rhythm without any significant abnormalities and without any ischemic changes as well.
Yeah. So how do you figure out prolonged PR interval on an EKG?
How do you define it?
Mhm.
More than, I mean, basically would be first degree AV block more than 200 milliseconds.
Yes, 200, which equates to how many small boxes?
5.
Yes, Lee, correct. Oh, good. So do we have here any PR prolongation? It's important to look at it, right?
No.
Any AV block looks like a very normal EKG, right?
Yes.
Okay, let's move on.
Further workup that we did for the transaminitis, a hepatitis panel was ordered, found to be grossly negative. To work up the anemia, we did a initial iron panel, showed a elevated ferritin, low haptoglobin, high retic count, 6.5. Anything else anybody would want to do?
So I think in the interest of time, if you want to
So
show us.
yeah, so at this point, we had a lot of the same concerns as you guys did about the geographic region that they were located in and some of the lab abnormalities, the signs of hemolysis. We were worried about parasitic infections as well. Actually went down and spoke to the patient and her husband at bedside, asked specifically about these walks that she was going on, how much time she was spending outdoors. And it turns out that he did find a bug on her at some point in her posterior axial fold, tried to pull it off himself about a week ago or 2 weeks ago and didn't think anything of it. And that at that point, we ordered further serologies. Should I go to the next one? We got a parasitology smear, which was positive for Babesia, 1.5% parasitemia. Lyme serologies came back as well. Lyme IgM was found to be positive. Further labs that started to come back later on, the blood cultures that were ordered on initial exam were negative. We did order West Nile initially, which was negative. Anaplasma was negative. The Babesia antibodies did come back negative. On the floor the following day, they did order a CMV and EBV panel, which were elevated, but per the ID notes, they didn't think that that really had much clinical significance considering we had a presumptive diagnosis of co-infection with babesiosis and Lyme disease. Should I go to the hospital course, Jackie?
No, just give me exactly a couple of minutes, Randy.
Please.
So,
Yeah.
Obviously hindsight is very, luxurious because now we can look back and say, oh, it always looked like hemolysis. And we can go on Frida's sort of quick memory recall of this, sort of combination of symptoms coming together to suggest Lyme. And so hindsight is a luxury, right? In that moment, what was cost effective and what wasn't cost effective is debatable. I actually reached out to some of our ID colleagues and I wasn't really able to get a word back from them.
Dr. S is on. Dr. Chapless, I just asked her to join.
Oh, to join the chat?
Right,
oh, thank you.
So just if you want at the end.
Hi, I don't know if you can hear and see me.
Yes,
yes.
Okay, I'm sorry I misunderstood the format, but anyway, thank you very much for inviting me. So I think what I would say, again, it's absolutely true in hindsight, but if you have fever and a tick bite, or if you have a tick bite of any kind, then I think that obviously that should clue you in 100%. So the CMV in that case really becomes a little unnecessary. So, I mean, I think your focus is kind of on cost effectiveness. Am I right?
Yes.
Yeah, so I mean, that's a very minor thing, but I mean, the minute you get the story of a tick, the kind of the diagnosis should really zoom in there. Now, I actually think that the blood cultures are totally appropriate. I mean, you don't want to lose time there, and God forbid you're wrong and the tick is the incidental finding. But the CMV, usually it's viral. You're not going to do anything about it anyway. So, there, I think that's important. So those were my immediate thoughts. I don't know if you need me to
thank you for
keep
bringing up
on.
this. No, I appreciate it so much. Thank you for joining, Dr. Stavropoulos. And I didn't even think about the CMV, but it's an expensive test, and the fact that it self-resolves, is important to keep in mind. What do you think about the hepatitis panel?
I think similar to the CMV, of course, hepatitis can do these things, but, again, it's not likely to give you the neurologic symptoms. And it's something that I think could wait a day, right? She's not icteric, although I guess not everybody has to be. But I think that would not be the leading cause of neurologic and fever. The neurologic complaints are, I think, really what is the most disturbing about her initial presentation. So I don't think hepatitis would really be part of that. We can wait a day. We can wait a day sometimes. I don't know.
Yeah.
Right?
Yeah. The other thing, again, just looking at this chart that we put together. So hepatitis, the acute hepatitis, so A, D, E, I'm sure you guys are aware there's a hepatitis A breakout in New York City. Those are numbers in the thousands usually. Very, very high transaminitis, tender liver, very tender to palpation. Hepatitis B and C, the chronic hepatitis, you can look back and LFTs have been deranged for some time, and they don't show up like this with the presentation that we saw. And then I would say, trope, $16 of a waste. At small waste, I would make that waste. And I think all of you in the discussion today convinced me that a head CT was probably necessary in a lot of ways, even on arrival. But I will continue to argue with Francisco about the TTE. I don't believe a TTE should be triggered right away till you have your blood cultures while you're digging for the most likely diagnosis. And then if the most likely diagnosis is not leading to something, then absolutely get your TTE. But it's an expensive study inpatient, and even outpatient is $500. So it's
right.
Yeah, I agree with that, because it used to be physical exam and symptoms that we relied on. It was very hard to get echoes back in the day. You didn't do that in the first 24 hours. It was something that you didn't expect for a bit, depending on where you were at. But I was always symptoms, clinical exam that helped you, and anything, the EKG was always considered to be like a way of like looking at what's going on with the heart and your vitals, of course.
Yeah, I would echo that, no pun there, that the TTE for an infection obviously is not indicated unless the blood cultures are positive, but the TTE as a possible, AFib or thrombus, I think that I guess can be argued. So I don't know I think that's tricky.
Yeah, with the ACCHA guidelines also, like if somebody is presenting with syncope, if I'm not talking about like going down the road of like, working up the infectious endocarditis, but just for the syncope, TTE is not even in the list of like investigation or the imaging you do or the procedures you do. Like you get an EKG, if you find something, well and good. If you don't, then you don't want to miss out anything and put them on telemetry for 24 hours. That's about it. Like there is a category of like mechanical or structural or like valvular etiology for syncope. We have EKG and physical examination for that. Can't just like jump to doing TTE right away. That's all about, that's what, our discussion is.
Me.
Sorry?
You taught me something. So thank you.
All right, Randy has a great presentation on the parasite. So Randy,
don't worry. It's it'll be here. Okay, so just to wrap up her hospital course. So when she was admitted, ID was consulted. Given the new history of the possible tick bite, she was empirically started on doxycycline, 100 milligrams twice a day. About 2 days later, we had the results of the Lyme serologies and Babesia. She was started on atovaquone, 750 milligrams twice a day, and a course of azithromycin. The Babesia parasitology was trended until the cultures were negative. And at that point, the patient's fever had resolved. Clinically, she was doing very well. And she was discharged to complete a 14-day total course of antibiotic therapy. She completed the azithromycin inpatient, and she went home with doxycycline and atovaquone, 14 days in total of treatment. And her hospital stay was a total of 7 days long. So to discuss a little bit about tick-borne diseases. So when we're thinking about
Sorry, may I interrupt?
Please, yeah.
Yeah, so I didn't see the chart, so I don't know.
Right.
So why was she in the hospital for 7 days?
So she was in the hospital for, they were trending the parasitemia. They were doing daily blood draws. It took, I think, 3 days for well, first it took 2 days for the initial cultures to be positive, and then it took 3 additional days for the Babesia to be undetectable.
So 5 days.
Yeah. But then also day of admission, in the ED.
Right.
So it may have been a day or so longer than it should have been, but that was the total.
How was she? Was she well?
Yes.
So that I mean, again, this is a bigger question, but that in the Hamptons, let's say in Long Island, where it's endemic, I mean, or in Westchester, where they see these cases every day, you might have argued that she's well. She could have gone home. She has no splenectomy, right? She's not immunocompromised.
No.
It's even questionable whether she needed to be, she could have all been done as an outpatient, frankly. I mean, I think the syncope was prior, right?
The syncope was prior, yeah.
Yeah. I mean, I guess I would have, if the husband brought her, I think I would have admitted her myself. But I think that once you've got a stable patient, she could have been dealt with more, I guess, more as an outpatient. And the only other comment I had is the Anaplasma serology, which is, I'm curious, so I want to know whether or not she was co-infected, but that doesn't change your management. So that becomes, if you're really doing cost, I don't know if that's necessary, but I think we academically like to know, and maybe even in terms of epidemiology, like to know.
No, 100%. That makes a lot of sense.
So Dr. Prophylaxis, do we have to keep the patients to follow the serology and finally waiting for it to come negative? I don't think so, right?
No, I don't think so either. And again, I understand the Babesia, you want it to be cleared, but there's really, if she's a normal host, I'm not really sure if that's absolutely, and she's stable. I think that that's not necessary either. You could follow it up in a week and make sure that everything is fine.
Thank you.
So just to run through a couple of things to know about ticks. So we know the important thing to know is that the vectors that we know cause disease, the Ixodes species of ticks causing Lyme disease, Babesia, and Anaplasma. The Dermacentor tick harbors Rocky Mountain spotted fever, and the amblyoma tick mostly harbors Likia. Anatomic sites to always keep in mind about where you could find ticks and where they're most common are areas that are most likely to come into contact with vegetation, or where ticks might be able to fall off of vegetation and be exposed to the skin. Things like the scalp, neck, axillary folds, which is where our patients was, waist and the belt line, gluteal cleft, popliteal fossa are some of the more common sites. In order for a tick to transmit disease, it's important to know that the tick must be firmly attached, and especially in the case of Lyme disease, the tick really needs to be firmly attached for 36 to 48 hours in order to start transmitting the Borrelia. This is because the Borrelia typically lives in the gut as opposed to Anaplasma, which lives in the salivary glands, and that's able to be transmitted much more rapidly. It's also important to note that if you do find a tick that is not visibly engorged with blood, then it's most likely that feeding has not begun on that person. And at that point, the risk of transmitting disease is much less, around like less than 1%. So if you do encounter somebody who has a tick bite, what do? The most important thing to know is you want to minimize the retention of tick parts, especially since we know that certain parasites do live in, say, the salivary glands of the tick. We don't want to leave any remaining parts of the tick in the patient where that can continually seed disease. So using tweezers or forceps, you want to go as close to the skin as possible. Grab the head of the tick. You want to avoid squeezing the body, since we know that some parasites do live in that area, like Borrelia, for example. And you want to pull perpendicularly while providing pressure to the skin. And this just ensures that you don't have any retention of tick parts. And you want to avoid squeezing the body, as I mentioned. So the Ixodes tick, we know, does harbor multiple parasites that can cause disease. One thing I just wanted to mention on this slide is that, first of all, the endemic region of the mid-Atlantic states, New England, and some areas of the North Midwest, notably Minnesota and Michigan. And it is typically the nymphal stage of tick that is responsible for spreading the majority of disease. And this stage of the tick's life cycle typically occurs in the late spring, early summer months, which is responsible for your Lyme disease season. So Lyme disease, like we said, caused by Borrelia. You can see on the right, this is the CDC map of the geographic distribution of the most common cases. And we'll go through the 3 stages of Lyme disease. So first is the early localized stage, and this is where you have your pathognomonic erythema, migraines, rash. One of the most important things to know, and one of the biggest takeaways from this, is that it's present in about 80% of cases of Lyme disease, meaning 20% of patients that come in do not have an erythema, migraines, rash. Our patient, for example, did not have a rash. Typically presents within 7 to 14 days after the inoculation. And it's sometimes easy to be missed. One reason is it can spread and enlarge slowly. So it might not enlarge until later on in this presentation, and someone doing a skin exam may miss it. But also, not every erythema, migraines, rash has this central clearing and target-shaped lesion. Sometimes it could just present as a homogeneously erythematous circular lesion. So if you have any kind of rash with this type of history in the right geographic region, don't let the absence of a target-shaped lesion deter you from Lyme disease. Otherwise, the symptoms of this stage are pretty nonspecific. Fever, anorexia, headaches, sometimes neck stiffness, myalgias, lymphadenopathy, fevers. Treatment for this stage, 100 milligrams of doxycycline twice a day for 10 days is the preferred treatment. If for some reason someone can't take a doxycycline, there are alternates like amoxicillin, but doxycycline is still the preferred agent. Now, later on in the presentation, early disseminated Lyme disease, this will present about maybe weeks, even early months after initial inoculation. It's a pretty dense slide. So just to cover some of the highlights here, the major takeaways. First of all, we were talking a lot about the cardiac manifestations. Atrioventricular block of varying degrees could present just with the first degree AV block, can develop into complete heart block in very severe cases. Myocarditis, pericarditis also are possible cardiac manifestations. Cutaneous manifestations, you might see multiple erythema, migraines, rashes. These are satellite lesions. Doesn't mean that there's multiple ticks. It just means that these satellite lesions are just signs of systemic disease. And the neurologic manifestations, there's a lot of different types of presentations. The ones that are really important to note is that you can get a meningitis that is probably the most common neurologic manifestation of Lyme disease. And your classic headache, fever, photosensitivity, neck stiffness. Cranial nerve palsies, they can mimic Bell's palsy, either unilaterally or bilateral cranial nerve palsies. Radiculopathy, neuropathies, ataxia. And some people may present with a mononeuropathy multiplex. You might have a radiculopathy in multiple sites that are not contiguous with each other. Any of these neurologic manifestations with the correct history should clue you in to check at least for Lyme disease. Now, late disseminated Lyme disease is something that we don't really see anymore. It seems like this is much more common in, say, the 70s and 80s before we truly knew or had a very good, stable regimen for treating Lyme disease early. But typically they would present with severe arthritis, either of the small or the large joints. And sometimes these neuropathies and radiculopathies can become more confluent and in some cases affect entire regions. Like sometimes it can resemble a stocking and glove distribution neuropathy. Now, treatment for disseminated Lyme disease depends on the acuity of the presentation and the severity. For acute neurologic disease, mild carditis, like early stage heart block, and initial treatment of arthritis, doxycycline, prolonged course is still your preferred agent. For people who for some reason may not be able to take PO, IV doxycycline is equivalent to PO, so you can give IV doxycycline. Now, for hospitalized patients who are more severe, say they're encephalopathic or say they're have a very advanced heart block, maybe a PR interval greater than 300, or even if they have developed into late second degree, third degree heart block, you might initially want to treat with ceftriaxone IV, and as because you want to cover for other possibilities as well. But as the Lyme's serologies begin to come back and the patient also may begin to improve at this point, you can transition them over to doxycycline just to complete this prolonged course of antibiotics. And one thing just to note, if a patient is presenting with heart block, you do want to keep in mind that you may have to temporarily pace them until their heart block resolves. Now, co-infection with Lyme disease, since we talked a lot about the Ixodes tick, it can harbor both Borrelia, Anaplasma, and Babesia species. In patients who have a diagnosis of Lyme disease, who have an unexplained fever that has persisted through the treatment of Lyme disease, and also if they develop a leukopenia, an anemia, a thrombocytopenia, a bilirubinemia, which is similar to our patient's presentation, you'd want to look for a possible co-infection with these other species. Now, in patients who are diagnosed with Lyme disease, about 2 to 10% of them may be co-infected with Babesia. About the same might be co-infected with Anaplasma. And it's important to check at this point because it might, it might depend on what treatment you decide for them. Now, in patients who are diagnosed, for example, with Babesia, because the incidence of these other parasites are not as high as Borrelia, about 50% of patients who are diagnosed with Babesia will also be co-infected with Lyme disease. So if someone has a diagnosis of Babesia, keep in mind that depending on the correct clinical scenario, you may want to check for Lyme disease as well. So serologic testing is something that can be very daunting. But when you get down to it, it's really not too difficult. The initial test to order, and we offer this test as well, is an IgM IgG ELISA. It is very sensitive for Lyme disease, but does have a slightly high false positive rate. Now, if the IgG IgM is positive, the confirmatory test is the Western blot, where they check multiple IgMs, 3 IgMs, and 10 IgG antibodies for Lyme disease. In order to confirm Lyme disease, either 2 of the 3 IgM bands must be positive, or 5 of the 10 IgG bands must be positive. In our case, these were our patient's lab results. you see 2 of the 3 IgM bands were positive in this patient's case, which was confirmatory of the diagnosis of Lyme disease in her case. But also it is important to know that the IgM does have a higher false positive rate, much higher than IgG. That's just something to keep in mind. Lyme disease prophylaxis. If somebody, if there is a history of a possible tick bite, you're really not sure, you're in an outpatient setting, and maybe the symptoms haven't necessarily presented themselves yet, the criteria for prophylaxing them with doxycycline, if they were able to save the tick, and sometimes we do tell, it is a good idea to save the tick if they're able to, and they're able to identify it as an Ixodes scapularis tick in the nymphal stage, depending on the size is one of the ways you could check. If they know how long the tick has been attached, if it's been attached for more than 36 hours, or if we don't know how long it's been attached, does it appear to be engorged with blood, that makes you believe that it has been feeding and you have a higher likelihood of contracting Lyme disease. If it's been within 72 hours of the tick being removed, and if the bite occurs in a highly endemic area, typically a one-time dose of 200 milligrams of doxycycline is effective in preventing disease. We had 87% of people, it was effective in preventing Lyme disease. So just to move on to Babesia, one thing just to note is that it does have the same geographic distribution as Lyme's, also the same vector, the Ixodes scapularis tick. Now, the severity of disease typically depends on the amount of parasitemia that you find on the smear. Typically less than 4%, you can expect mild to moderate disease. Our patient had a 1.5% parasitemia. Most of the symptoms are nonspecific, similar to Lyme, and you may not even see much on the physical exam that will clue you in. Sometimes if there's high hemolysis, you can see sclerolicterus, you can see some jaundice. A rash is extremely uncommon. If you do find a rash in a patient that has Lyme as Babesia, have a high suspicion for Lyme disease as well, and you should test for it. But one of the things that's going to clue you in are the lab abnormalities, signs of hemolysis, acute low hemoglobin, low haptoglobin, reticulocytosis, and elevated LDH, and indirect bilirubinemia, and AST greater than ALT. These are some of the things that can clue you in. Also, thrombocytopenia as well. That's unexplained. Severe disease, babesiosis, typically parasitemia greater than 4%. The clinical manifestations are largely the same. However, they can be more pronounced and last longer, and these patients are more predisposed to having relapsing and remitting disease. These are your immunocompromised patients, asplenic patients, patients that are receiving immunologic therapy, and some complications, severe complications in these patients: ARDS, DIC, renal failure, very severe anemia. Diagnosis: Babesia can be visualized on staining under direct microscopy. If it's very low parasitemia, you may not be able, it may be missed. So that's just one thing to keep in mind, and that PCR is much more sensitive. However, PCR is also expensive, and not every center has PCR for Babesia. We do have in our system, and we did order it initially, antibody testing. There is very little role for antibody testing because the presence of IgM and IgG antibodies can be delayed in response, and they may even persist longer following treatment. So it's tough to discern an old infection versus a new infection. Treatment: people can be found to have parasitemia asymptomatically, in which we do not recommend treatment. For mild and moderate disease, 3-day course of azithromycin plus a 7 to 10-day course of atovaquone is typically the treatment. Same for people who have severe disease. However, it's important to know that for your immunocompromised patients, you might want to prolong the course of azithromycin until the symptoms resolve, or when the parasitemia declines. And if the parasite load is greater than 10%, you can consider an exchange transfusion. One thing I'm just gonna rocket through these pretty quickly. Anaplasma and Likia, typically we think of them together because the presentations are very similar. The major differences, if you look at the geographic distribution, Anaplasma very similar to Lyme. Likia, you're looking more South Central United States, Southeastern United States. Most of the presentation is again non-specific. However, more severe disease is possible in ehrlichiosis. And these are more severe diseases, more common neurologic presentation, encephalitis, altered mental status, neck stiffness can mimic a meningitis. So that's just one thing to keep in mind with Ehrlichia. Diagnosis is the same. PCR is definitely the most sensitive way to find it. It also can be visualized under direct microscopy. And treatment for Anaplasma and Ehrlichia, doxycycline 100 milligrams for 7 to 10 days, which, as we were saying earlier, is a similar treatment to Lyme disease as well. That's really it.
Thank you so much, Randy, for a really great case and a wonderful presentation and overview. I think in the interest of time, we might have to leave it there, but thank you so much, Dr. Sharma, Dr. Singh, Dr. Osorio, and Dr. Stavropoulos for a really excellent discussion as well.
Yeah, thank you. Thank you.
Thank you, everyone, and see you all next week.